Hi everyone, I'm Dr. Alexandra Abbott. I'll be discussing with you ankle injuries and some specific nuances for youth soccer players. We'll start with the stats. A large study that included over 1.5 million soccer-related injuries dissected out that 18% of them were ankle injuries. So about 1 in 5 soccer injuries that need a doctor right now are of the ankle. We're publishing some more data from a large group of over 60,000 pediatric patients next year, which shows that about 1 in 4 of kids' musculoskeletal injuries and about 1 in 5 of their broken bones are related to the foot and ankle. As kids get older, they have a higher risk for a fibula fracture, which is commonly sustained from rolling the ankle or inversion in sport. A little more than 1 in 10 of the fractures in teenagers are of the fibula. So overall, kids hurt their ankles and break their ankles pretty frequently, and it results in a lot of young soccer players having to go to the emergency room. More stats. A study last year that compiled the data from over 100 other studies of youth soccer players found that the ankle is the most common injury site for them. Concordant with our study, they found that the risk for ankle injuries is higher in older children like teenagers. Many studies have demonstrated about a 25% higher risk for ankle injuries in female athletes than male athletes, but the prevalence for all soccer players to have an ankle injury is high, up to 50%. Many studies use the metric of hours of exposure in sport to quantify how frequently injury occurs. If we crunch the numbers, we can convert this to metrics that apply to our kids. For boys on average, we see 6 ankle injuries for every 1,000 soccer hours. This converts to an ankle injury every 3 to 4 months if a boy is playing soccer 10 hours weekly on average. For a year-round soccer player, that's an ankle injury every season. This study from 2022 looked at just high school athletes and similarly used 10,000 athletic events as the denominator to quantify the ankle injuries. To crunch this into real-world numbers is more difficult because your kid will probably and hopefully not have 10,000 athletic events in high school. But if you take 2 teams of athletes from a high school who are playing 5 times a week, you can expect that group of about 64 athletes to have 3 ankle injuries per year. Imagine how many a whole high school of teams would have, especially if they're playing more frequently than that when they're in their season. The risk is nearly doubled for soccer players. So a high school athletic trainer who's responsible for all of the high school teams, or even just an athletic trainer for a couple soccer teams, needs to know how to manage ankle injuries. So to sum up those stats, ankle injuries are common, and female athletes, teenagers, and soccer players are at the highest risks. But how do ankle injuries happen? An acute ankle injury or a sudden injury usually happens when someone rolls or inverts their ankle. Inversion injuries can be made more severe if it happens with a slide tackle or some other collision. A chronic ankle injury describes ankle pain that didn't start from one discrete mechanism and came on more gradually. We found that ankle injuries are more likely to occur when someone has poor balance, which we have learned can be studied accurately with the STAR balance test, when someone has a history of ankle injury, and when someone has relative weakness in the posterior chain, which are muscles in the back of the leg. When someone has a history of an ankle injury, the hypothesis is that their ligaments are less tight because of the trauma, modeled by this rubber band that's being stretched repeatedly and you can imagine would have less elasticity than one that was never stretched. Someone with a history of ankle injury has also demonstrated that they have maybe suboptimal biomechanics that need correction before their risk for a repeat injury is decreased. Not everybody who rolls their ankle will get an injury, but some signs of injuries include pain, swelling, bruising, stiffness, and difficulty or inability to put your weight on it. Chronic ankle pain might limit training or make someone run or play differently to avoid the pain. Ankle injuries include acute ones like sprains of the ligaments, fractures or broken bones, and in kids, growth plate injuries. As we discussed before, teenagers are particularly susceptible to fractures of the fibula growth plate when they roll their ankles. We think that the intersection of high forces in teenagers, but still with open growth plates during those teenage years, give them the higher risk for hurting their growth plates than the younger kids who also still have open growth plates. In addition to the common ankle sprains of the ligaments that connect the foot bones to the ankle bones, sometimes you might hear about a high ankle sprain. This just means that the ligaments that are involved are the ones that connect the bones in the shin. Those are the tibia and the fibula. The high ankle sprain is rare because the mechanism requires the foot often to evert or roll outward instead of inversion, but also at the same time that the shin bones are rotating in the opposite direction. We see this most commonly in football players because of the weird and ugly ankle movements that happen when someone tackles you in a random direction while you're running away. Commentators will cringe when they hear the doctors diagnose a high ankle sprain for somebody on their fantasy team because the recovery time can be twice as long as the typical ankle sprain. For chronic ankle injuries in children, we commonly diagnose severs, osteochondritis dissecans, overuse injuries, and ankle impingement. Sever's disease is just a dramatic name for inflammation or stress at the growth plate in the heel, usually from trauma like jumping, running, and tight calf muscles making the Achilles tendon yank on the growth plate. We see this commonly in gymnasts and dancers, but many young athletes will go through this. Pain at the growth plate goes away once the growth plate closes during puberty, but kids don't have to be miserable while they're waiting for puberty. Heel cups can offload trauma to the heel and can be inserted like an insole in your shoe. Ice and NSAIDs like ibuprofen for anti-inflammation can reduce that inflammation and pain, and stretching the calves can help take the pressure off of the growth plate from the muscles above. Our next injury, not the OCD that you typically think of, osteochondritis dissecans describes an abnormal separation of the bone and cartilage inside the joint. This can happen in the ankle joint between the first bone in the foot and the last bone in the leg and can cause sort of this chronic ankle pain picture. We most commonly see OCD lesions in patients aged 10 to 20 years old, and we use X-rays and MRIs to grade them. Depending on how much inflammation and separation there is between the bone and the fragment of bone, rest to stop repeated trauma can resolve the lesion. Advanced or high-grade lesions need surgery, though, to fix them. Chronic ankle pain can also be from muscle or tendon strain, typically when someone has progressed too much or too fast in their exercise volume, or when they don't allow enough rest and recovery for the structures to adapt to that new exercise load. The treatment for strains is rest from painful activities. The last specific ankle injury that we'll discuss is ankle impingement. We see this most commonly in older athletes where repeated trauma to the ankle results in scar tissue forming from the soft tissues and osteophytes or bone spurs of the bones in the ankle developing. The soft tissues in the bones essentially think they're being helpful by growing hard structures like shields in the direction of stress, but these hard structures act like monkey wrenches inside of a joint that's trying to hinge. These cause pain and decrease your range of motion in the ankle as these structures are getting pinched in the ankle joint. You can see an X-ray on the bottom left picture showing osteophytes and an MRI to the right of that showing additional inflammation with that white signaling and scar tissue. This is a pro soccer player who has anterior and posterior or front and back ankle impingement or pinching ankle. Often, differentiating which ankle injury has occurred can be sorted by understanding the mechanism of injury from hearing the patient talk about it and with a physical exam. Providers will often use the Ottawa ankle rules with their physical exam to try and correlate the risk for fracture and subsequently how useful an X-ray would be based on where the pain is in the foot and the ankle. Ankle injuries are commonly treated with ice, anti-inflammatories, rest, and compression for the swelling. If someone can't walk or they have a broken bone diagnosed, we'll use a cast or a cam boot and maybe crutches to immobilize and rest the ankle so that we can optimize the healing of the bones and the ligaments affected. After a sprain, lace-up ankle braces are often used for 2 months after the pain has resolved because of the high risk for repeat sprain with those loose ligaments that we talked about. Some people opt to use lace-up ankle braces long-term to prevent re-injury because of that increased risk. Of note, lace-up ankle braces have been studied as superior to ankle taping and as superior to the high-top style shoes for preventing ankle injuries. Ankle injuries can be prevented with neuromuscular training, ankle strengthening, and improving ankle proprioception. We call this prehab if you don't have an injury yet, but you want to make sure that your biomechanics support you. In kids with open growth plates, we think about protecting them from overuse injury more conservatively. So thinking about rest when someone's complaining about pain and complete shutdown from activities, especially if someone's limping from pain. I could offer a completely separate talk on this topic, but we've learned that athletes are at higher risk for injury when they don't follow the specialization rules of thumb. These are when they don't have at least 1 day of weekly rest, when they don't have an off season of 3 to 4 months when they're focused more on rest or another sport, and when they exceed the number of their age for weekly hours in a primary sport. So the 9-year-old who plays 12 hours a week of soccer on all the travel teams with no rest day because he works on penalties on Sunday will be seeing me in my clinic. Finally, I include the lace-up ankle brace as a preventive option again and remind you to see me for an x-ray if you're worried about a broken bone. And then lastly, I included this study, which was a really good one recently, that showed that AstroTurf seems to set athletes up for more injuries, especially in the lower extremity. The thought is that on turf, there's a different biomechanics that occur compared to natural grass, and that for ankle injuries, soccer players load the outside of their foot by the pinky toes more when they're landing. And as you can imagine, that would set you up for a higher risk for inverting the ankle or rolling it inwards. We included our references in case you'd like to read the primary literature yourself or to read more about ankle injuries in general. And we thank you for attending our webinar. Also for your reference, we included the list of Stanford pediatric primary care sports medicine physicians in the area. We'd be delighted to take care of your young athletes. I won't tell you how old this photo is, but I had to include it to give you an insight about where my passion for sports medicine started. Thank you.